Welcome, friends. It is our great pleasure to introduce you to SICOT Pioneer. Pioneer is a program of innovative orthopedic networking, e-learning, education, and research that was designed to fill the gap left by the absence of face-to-face meetings, courses, and other activities during the 2020 coronavirus pandemic. But Pioneer has become so much more than this in the intervening year. Pioneer is a virtual, but also very real community of like-minded orthopedists striving to help not only themselves, but one another. With the latest video conferencing and educational technology, as well as a groundbreaking online platform, SICOT's Pioneer events, activities, and resources are reaching every corner of the globe, with over 55,000 views of our webinars so far. We're forging new partnerships, signing agreements with 12 other international academic societies, and building an enduring network we hope will last for many years to come. So, what can you expect from us? Free webinars led by key opinion leaders from around the world and across all fields of orthopedic surgery and traumatology, as well as chat shows with some of the most interesting and inspiring surgeons on the planet. Opportunities to take an interactive role in these webinars by participating in polls and live discussions. Free on-demand Pioneer playback service. Watch our webinars again and again in your own time. And coming soon, our new bespoke learning management system will host podcasts, an online version of the famous SICOT diploma exam, virtual training modules, surgical technique courses, a discussion forum, and much, much more. We hope you'll join us on this pioneering journey as we push the boundaries of what is possible in online orthopedic education together.
Good morning, good afternoon, and good evening to our global audience joining us this evening on SICOT Pioneers webinar on elbow pathologies. My name is Gaurisan Thevendran, and I'm the Education Academy Chair for SICOT. And it's really an honor to invite you to join this collaborative effort where SICOT meets Europe. It is indeed an honor to introduce the chair and co-chair for this session. The chair being our very own outgoing chair of the Shoulder and Elbow Committee, Professor In-Ho JEON from Asan Medical Center in Seoul, South Korea. He's also the APOA Hand and Upper Limb Society President-elect and an upcoming leader in the SICOT community. Alongside him, the co-chair for this session is Professor WEGMANN, who is a senior consultant shoulder and elbow surgeon from the München Clinic, Munich in Germany, and also the second vice president of the German Association for Shoulder and Elbow Surgery. And alongside these two reputed gentlemen, we have 9 other panelists from 5 other continents contributing to the vast knowledge and experience in this remit of elbow pathologies. Without further ado, I would like for us to proceed with this webinar, but to remind all our virtual audience, please contribute with questions. We'd like to hear from you, both comments and queries. So please present them in our discussion box, and the panelists will discuss them as we proceed or towards the end of the webinar. And on that note, welcome again to this elbow webinar. And In-Ho, over to you.
Thank you, Gao. Dear ladies and gentlemen, friends, welcome to a SICOT Pioneer Elbow webinar. First of all, I'd like to send my sincere apology for delay because of technical issues, but we are all ready to start our interesting webinar today. This webinar is a very unique webinar because, as far as I know, none of these webinars really focused on elbow pathology for the last 2 years. So we have wonderful faculty members from European side, and we have wonderful faculties from SICOT Shoulder Elbow Committee, and you will hear all the debatable issues today to solve your questions. So without further delay, I would like to introduce our co-moderator, Professor WEGMANN, and he is going to introduce the first speakers. KILIAN, over to you.
Thank you for the introduction. I think this is a very special meeting because it's international, intercontinental. This is something that is rarely done, and I think it's a very exciting idea because, in my experience, when crossing continents, we can very much learn from each other because clinical practice will always differ a little bit when crossing continents. So I'm very excited to look forward to this meeting. And the delay, I think, only added to the excitement. And so I think we shouldn't hold us much longer and start with the first talk. In the first talk, I'm very thankful to have Guido Fierro from Colombia here. He's a renowned elbow specialist, and I'm looking very much forward to hear his talk on lateral elbow pain and differential diagnosis, which we all know is a complicated problem in daily clinical practice. So please, Guido, start.
Thank you very much, KILIAN, for this kind introduction. Thank you very much to all the commitment. And as you say, I think it's good to start right now. Okay. This is the first talk about in this webinar is lateral elbow pain and what happened if I'm not sure if the patient have epicondylitis. What happened with the other diagnosis? This is my hospital in Bogota, Colombia. You are more than welcome to come. In this talk, I'm going to talk about the origin of the pain, the lateral epicondylitis, diagnosis, treatment, and some differential diagnosis. But what happened when you are facing a patient with a pain in the elbow? And more than that, the patient is clear to say, hey, I have pain in the lateral side of my elbow. In that moment, you need to divide your brain. You need to think that maybe the pain is come from the elbow itself or from the other part. From the elbow in itself is maybe the pain is from the cardiole, the bone, the ligaments, tendons, capsule, and bursa. You have many structures that probably you will have a problem. In a cardiole, you will have also osteoarthritis. If the patient is an old patient and the patient refers that there is pain and some cracking in the elbow, and of course the OCD. But look, you have in the same structure you have two different pathologies, OCD and osteoarthritis. Then you're thinking, okay, maybe my patient has a problem in the bone. Okay, you're thinking fractures, of course. And ligaments, maybe instability or microinstability. We will have a talk after about this topic actually. And then the tendon, you think, okay, the problem is in the tendon. Now appear the epicondylitis, or maybe it's a really tendon tear in this tendon. The capsule, probably the patient is starting to with an elbow stiffness, and one of the symptoms is pain. That is the other diagnosis that patient can have, or bursitis. Then after that, you're thinking, okay, this is the problems that my patient could have in the elbow because it's an elbow problem. But what happened? The problem is not in the elbow. Now you need to start thinking in nerves. Start to thinking in syndrome, in radial tunnel syndrome, pronator teres syndrome, carpal tunnel syndrome, and a radiculopathy problem. Of course, the patient can have other systematic problems that gout or septic arthritis. And remember the shoulder. Sometimes the elbow pain is not come from the elbow and not come from the nerve, come from the shoulder girdle problems. Okay, remember the anatomy. It's easy if you focus your patient in that way. Thinking an elbow like a box, have anterior, posterior, lateral, and medial part of that box. In this talk, we're going to talk, of course, about the lateral side. But it's not about just the anatomy. It's just about the function of the elbow, thinking. And this is kind of the way that we think in the shoulder. We need to focus in movement, some movement problem, stability, strength, and smoothness. And then if you combine these four areas to evaluate the elbow and the anatomy, then I'm pretty sure you will find the right diagnosis. And then remember, shoulder assessment, shoulder girdle, and the contralateral elbow in every patient. Okay, remember, we can have problems in tendons, of course. We can have problems in bones, in ligaments, or in nerves. And after that, we have that problem in mind, we need to focus in the history of the patient. And the history of the patient, and the reason about this talk, is the history is a lateral elbow pain, and the vast majority of the patient with this lateral elbow pain has epicondylitis. The epicondylitis is was described many years ago, in the last century, affected 3% of the population. A lot of people can have epicondylitis in some point of the life. What happened? What happened is like a micro trauma and excessive movement in the extensor carpi radialis brevis tendon. And why this tendon affect? Because it's a small tendon, is below the extensor carpi radialis longus, as it is close to the joint. And the reason, because the shear forces in this tendon can affect that tendon more than the other tendons. Of course, the problem, I mean, it's easy when you explain this for the patient, you say, hey, it's a tendinitis, some inflammation, but it's not an inflammation, it's a degenerative problem called angiofibroblastic hyperplasia. And then when you try to understand the histology and the physiopathology of the problem, then you can understand, at the end of the talk, what many of the treatment just don't work. Okay, now the patient is in your clinic. At the beginning, you just need to, at that moment, you don't know what the patient has. You ask for the movement, like an active and passive movement, of course, in a flexion, extension, and pronosupination of the elbow. And it's just an inspection. But when you are thinking in an epicondylitis, the test for epicondylitis are these. The best test is try to find the point of the extensor carpi radialis brevis. Just try to find the point, and it's not in the tip of the epicondyle. It's more anterior and a little distal because it's in the insertion of extensor carpi radialis brevis. Then you start with the other test, like an extension of the wrist, extension of the fingers, in the elbow, in flexing position, and with the elbow in extension. Look. You try at the beginning in a flexion, then in extension. Then this is a kind of a shear lift test because it's not effective as for a shear, but the patient just grab your arm and that's it. And there are other tests thinking in the differential diagnosis, that is like a pronation and supination against resistance. This is like a other situation that always the patient refer that, hey, when I try to grab my laptop or a book in my back, I feel pain in my elbow. That is epicondylitis. And this test, I learned this test from Dr. Driscoll, actually. That is a tennis elbow shear test. This is when you have some doubts about the diagnosis, then you do this, extend your elbow, they flex it in a different movement, increasing the velocity of the movement. Then the idea of this test is increase the shear forces against the extensor carpi radialis brevis tendon. Those are the tests for the lateral epicondylitis. And of course, you need to check the ulnar nerve, you need to check the medial epicondyle, of course, but all those tests that I just showed you was for lateral epicondylitis. Okay. And the image, of course, you don't need MRI, you don't need CT scan, you just need an X-ray. Why? Because the things that you really want to see is nothing. You want to see a normal X-ray. That is the reason, because we just need an X-ray. All those changes in the MRIs, we know already with the clinic. We know what happened with the extensor tendons. But maybe the patient has an OCD, arthrosis, tendon calcification, and that is the reason because we just ask for an X-ray at the beginning. Maybe if the patient don't improve or you have some doubts about the diagnosis, then you ask for MRI. Okay, the treatment. Now we start to talk about the treatment. The treatment, you really need to differentiate the treatment in 3 points, in 3 groups. The first group is a non-operative treatment, of course. And then we have activity modification and education. This is the key of the success, the education of the patient. If you just tell the patient, okay, you have epicondylitis, take these drugs, this shot, and that's it. Probably, I'm pretty sure that patient won't improve because he or she really doesn't know about what is happening with the elbow. The physiotherapy, and we are going to talk about that after. The anti-inflammatory medication, pills, bracing, shock wave, and the group that I call injection. And in this group, the acupuncture is in this group. Okay, thinking in just 3 groups of the treatment. The first one, the first shot that you have, in my opinion, is the most important shot that you have. And this group of treatment include education, physiotherapy, pills, some topic anti-inflammatory, and corticosteroids, but not in the elbow, in the muscle, in the back. Okay, that is the first group of the treatment. And why? Because remember, this is not an inflammation. This is an angiofibroblastic hyperplasia. It's a degenerative problem. You really need to stop the problem with the patient. You really need to be aggressive with this pathology at the beginning. That is the key at the beginning of the pathology. Remember, education. Explain the patient what he has or she has. Explain what happened, these problems, and try to ask for the current situation of their life. And then probably you can help the patient to stop the things that brought the patient with you. Okay, the second group is the group that is like in the gray area, because everything works and everything doesn't work at the same time. You can find many description of the treatment, and we are going to see that. And the third one is the surgery. Okay, the first group, activity modification, just try to explain the patient what he has, and then try to stop to correct those habits. Some authors in the acute epicondylitis recommend this: just rest, ice, brace in the wrist, and some elevation of the elbow. That is in the very acute phase of the disease. Then the physiotherapy. What are the things to remember in the physiotherapy? Of course, the idea is the patient improve the function, decrease the pain, but the exercise that we really need to recommend to the patient is this exercise, eccentric exercises. And it's more than that. It's not just to prescribe the physiotherapy. You need to teach the patient and you say, hey, the most important time to perform the physiotherapy is after you just awake. You awake in the morning and try to do those exercises. And you can repeat it 6 or 7 times during the day. I mean, it's an extension, reflection, doing the eccentric exercises with the other hand. That is for free, and it's very, very important for those patients. And after that, after eccentric exercises, and the patient decrease the pain, then you start to strengthen the muscles. Okay, what happened with the medication, with the pills? In theory, there is not a big difference between the oral or topic medication, but as I told you before, remember, you need to be aggressive. In my practice, I use the 3 medication. I don't care about this difference. No, I use everything. I use oral, topic, and corticosteroid in the muscle, not in the tendon. Okay. This is the first shot. What happened with the corticosteroid injection? This works, of course, works the corticosteroid injection in the short time. But what happened in the middle and long term? Probably the patient will have a damage, and after 3 months, the patient can have the same pain and the damage in the tendon. That is the reason, because we don't want to start using the corticosteroid injection in the first 6 months of the disease. Remember, the corticosteroid can weaken the tendon, create a iatrogenic rupture, muscle or skin atrophy. Okay, what happened with the Botox? We all know how the Botox works, but this therapy is not for sure. We're not sure that we will work. in what patient can we use it? In a refractory chronic lateral epicondylitis. I mean, the patient that you are in the doc, okay, maybe I need to do surgery in this patient. That is the patient that probably you need to consider the botulinum toxin. But we don't have a good and strength studies about this treatment. But the thing is that if you are going to use it, remember, using in patient with not in the acute phase, with pain, the moderate score, in a refractory chronic lateral epicondylitis, and those patients, as I told you, that you think that this is for surgery, you can try the Botox. Okay, the hyaluronic acid is a pain relief, of course, yes. In theory, in some series of patients, decrease the tendon thickness and neovascularization. That sounds good when you are facing angiofibroblast dysplasia, but what happens if you compare with other treatment? We don't have a very good study comparing with other treatment. Right? The reason because we are not for sure if the hyaluronic acid can work, because the proof of the patient that use it is similar to the other series with other treatments. Okay, what happened with the PRP? That is a very, very interesting discussion, and the shockwave, of course, because the PRP, you can find this is a resume of all the literature. Believe me, if you go to PubMed and you find and you try to search and study about these things, you will have some papers with a relative design that say, hey, plasma works, maybe not much, but yes, works. But you can find a bunches of papers that say this is not a different, you cannot use it. I mean, if you compare with the other techniques, probably the PRP will not improve so much. And now we start to thinking in value. That is the thing that we need to provide to the patient, not treatment, a value in what we do with the patient. Okay, what happened with the dry needling? This is the cheaper treatment for this pathology and work. I mean, this is a technique that is cheap, easy, fast, and if we compare with other techniques, works very well. And if we compare with the corticosteroid injection, improve the pain even better than the corticosteroid injection after 6 months. Okay, and what happened with when we compare PRP, dry needling, and corticosteroid? Yes, the dry needling is the winner. If we compare with this with the other technique, if we thinking in value, remember thinking in value. And the shockwave, what happened with the shockwave? This is interesting because everybody that have a shockwave machine in his own clinic think that works. And of course, provide to all the patients. But when you facing the literature and you facing the real evidence, probably after 3 months or 6 months, the patient will be at the same if we perform other techniques for treatment. Okay, remember, look very well in the literature and ask for value in your treatment, not just about the fancy thing. No, try to provide value. And what is value? What is the cost that I pay? I mean, it's not just money, it's money, time, pain, and the thing that I'm going to earn, I'm going to have. If we compare, and we are thinking in provide value to the patient, probably PRP, shockwave, probably it's not a good option in my opinion, but I'm open to the discussion after this talk. And the other technique, this is the brand new technique, not brand new, probably just new, is ultrasonographic percutaneous sternotomy and works very well. This is like an option before the surgery, works very well, and use ultrasonic energy. And the idea is create a micro resection of the tendinopathic tissue in the extensor carpi radialis brevis. That is the idea. It just has very, very small incision, and after 6 years, the patient keep without pain. And of course, we have surgery. Surgery. I'm not going to talk about surgery.
Guido, yes, KILIAN. I'm sorry.
I'm going to finish. This is my last slide.
Yeah, but I wanted to give you time to answer one of the attendees' questions, because after that we will have to close and move on, because we're on a very strict schedule, and you're not much over time. But I wanted to give you the opportunity to answer this question. And I think it's a very interesting question. One attendee asked if you have the experience that shoulder problems come along and introduce elbow pathologies like epicondylitis. Is that something that you have experienced?
Yes, some patient with shoulder dyskinesia, and I had the problems. When a patient go to your clinic and for an elbow pain, and that is a mistake, but you're always thinking in the elbow, and the elbow you say, okay, let me check the elbow, and you find almost nothing, some tenderness, some pain, but it's not clear. If you have that patient, I mean, a sport guy, probably you really need to focus in the scapula, because that patient could have scapular dyskinesia.
Okay, very good point. Scapular dyskinesia is something very important in that regard. We have to take into consideration. So thank you very much for this beautiful overview. Inho is going to introduce our next speaker.
Sorry for the time.
No.
Yes.
The main delay came from from technical problems. So, but we are under some pressure now. So Inho, please go on.
Yeah. KILIAN, thanks very much. Our next speaker is Dr. Roger van RIET. He's going to show us the arthroscopic management of lateral elbow pain. I think Roger is ready for your presentation. Go ahead.
Hi, my name is Roger van RIET, and I was asked to talk about arthroscopic management of lateral elbow pain. I have some disclosures. I'm a designer with Acute. I'm also a designer of this temporary immobilizer called the Exo Elbow by Jake Design. So lateral elbow pain can be several things. It can be tennis elbow, plica, fractures, cartilage pathology, and maybe instability or OCD. And all of these can give symptoms on the lateral side of the elbow. As you know, arthroscopy is also named keyhole surgery, and through that little keyhole, you're trying to see the entire picture. And really, very often, it's easier to see it through the camera than when you compared to when you make a big incision. So tennis elbow has a lot to do about arthroscopic release of lateral epicondylitis, and there are many, many different ways. I prefer to be simple. So this was a patient with the refractory tennis elbow. We don't operate unless they have more than a year of symptoms, have tried physio, etc. And what I basically do is I basically do a percutaneous release. So this is fairly similar to what you would do if you didn't look at it through the scope. So a percutaneous release of the tendon, you release it off the lateral epicondyle, and you release it away from the LCL complex. So you stay anterior to the LCL complex. And then what you do is you start cleaning it up, shave the lateral side of the epicondyle, and freshen up until you see proper tendon tissue. It's an excellent way to learn how to do arthroscopy if you're in the beginning of your learning curve. And there we see the muscles shining through. That means we've done sufficient debriding. You see the healthy tendon there on the posterior and anterior as well. This is also lateral elbow pain. This is a very inflamed plica. As you can see, the anterior part of the elbow, anterior view. You see some cartilage damage on the radial head. It was a previous radial head fracture. And then I created a different portal. Again, you saw me do the percutaneous release with the tennis elbow. And basically, this is more or less the same portal, because you don't want to be too far anterior, as in that way it's very difficult to remove that plica. So if you come almost straight lateral, just anterior to the LCL complex, you can remove it. Very often I'll release the annular ligament a little bit to make sure that the tension is off and it won't impinge anymore. So again, debride it, and then go to the back of the joint after this and have a look, because obviously the plica is a 360-degree anatomical structure, almost 360. So again, cartilage damage under the plica, which is very common, but doesn't really affect the elbow that much because it's not in the load-bearing area of the radial head. So same thing, this is the posterolateral view and the posterolateral from the posterolateral portal, and the shaver is in the soft spot portal. You can shave quite a bit here, but obviously you don't want to go through the whole of the lateral tissue, because then you might end up in the lateral collateral ligament, and you don't want to cut the lateral collateral ligament, obviously. Yeah. Lateral elbow pain in young patients, definitely not lateral epicondylitis, more likely to be something like a plica or OCD, as in this case. So you see some sign of itis, but otherwise normal elbow, excellent cartilage from the anterior view. Then we go to the back. Always check the medial gutter, so all the nerve is just behind that, but loose bodies really like to be there. There's your olecranon fossa, olecranon tip, follow it laterally, and then move your camera, slide the camera into the lateral gutter, where we'll see, I'll turn the image, and there you see the OCD lesion. I think that was a good indication for arthroscopy, because it was about to come loose and disturb the rest of the elbows. I don't do ice picking. What we do is we debride with the shaver, and the bone is usually very soft, so you can go to bleeding bone just by using the shaver. I think that's more elegant, because you're sucking up all the bone debris as well straight away. Different type of OCD. Failed conservative treatment, so she stopped. She's a gymnast. She stopped doing that for a while, and unfortunately for her, the symptoms didn't resolve. Fairly similar to the previous one, so it looks good. Medial gutter, olecranon tip, and then again lateral gutter, and there's the lesion. So intact cartilage, but the lesion is definitely loose. So in this case, we decided not to debride it, but to actually fix it. So we used fluoroscopy. We did some subchondral drilling into the lesion in hope of inducing some bleeding, and then finally we fixed it with PDS suture. So we used suture retriever, PDS through the suture retriever all the way up, so it's posterior to the elbow where the knot came afterwards. So we pre-drilled. In this case was retrograde drilling, and then this is where our suture ended up. Together with the pin, get the suture retriever through the hole, and that's quite tricky, because obviously you don't want to be pushing on that fragment, so you definitely want to be really in the drill hole that you made. So suture ended up at the back of the elbow. We tied them and fixed it. There you go. So quite a stable fixation, and quite happy with that. Now this is also a young patient, loose body in the back of the elbow, of course. As you can see on the CT scan, this is the front of the elbow. This is a professional tennis player. He's only, I think he was 21 when we did the surgery. So clean up the osteophytes, again from the lateral side. You see my lateral portal here is far more anterior than it was when I remove a plica or when we do a tennis elbow. And again, this is the back of the elbow posterolaterally. You see the havoc that has been wreaked by the loose bodies. So the loose bodies were removed quite easily. Lateral elbow pain again. He's a goalkeeper, a little bit older, professional goalkeeper, and he had quite a lot of pain on his, again, lateral elbow. Was already treated for so-called lateral epicondylitis, which I think he didn't have. And then on a CT scan, we saw a loose fragment on the lateral side of his trochlea, and that loose fragment was giving him pain. There you go. So it's quite high up. It's a little bit more difficult to remove, but basically just removed that loose fragment, debrided the area, and he was back in the goal within a couple of weeks. To debride until there's a stable situation, of course. Then this patient had an elbow dislocation, again lateral pathology, so extended tendons ruptured. Unfortunately, on the medial side, some pathology as well. but extensor tendons ruptured, LCL ruptured, and this is something that can be treated arthroscopically as well. As you can see, I like my PDS sutures because they're quite stiff and they're easy to manipulate. So 2 PDS sutures through the stump of the LCL complex. We use an all suture anchor on the lateral epicondyle. It's very easy to see where the ligament came from. This is actually the hardest thing to avoid soft tissue bridges. We pull the sutures out of the soft spot, and then as you can see, when we tie the sutures, we actually stabilize the elbow. I can't show you the end result because I always take the camera out when I actually suture the anchors. Then this technique is what we use in chronic LCL insufficiency, not in grade 3. So if there's really recurrent dislocations, I prefer to do a ligamentous reconstruction that we still do open. But this is we call this the LCL imbrication technique, where we go in with the 14 gauge needle on the lateral epicondyle, get the PDS through in the radial gutter, take it out of the soft spot, and then do the same from the distal end of the LCL complex. So on the subcutaneous bone of the ulna, follow the bone, so I really stick to the bone, so I'm not injuring any other structures, and then end up again in that posterior gutter there. Now we have 2 halves of the reconstruction or the repair or the imbrication, however you want to call it. So we connect these two, and then you pull it to one side. So pull it through, and now you have one suture going from the origin to the insertion of the LCL complex. We double it up, so we get a second PDS, pull it through halfway, so now we have so-called basically 2 strands. And in this patient, we pulled it distally, as you can see in a second. So pull it through, and now we have 2 strands of PDS running from lateral epicondyle intra-articularly to the distal insertion of the LCL complex. Then retrieve both ends subcutaneously. And then once we tie this, we have an imbrication of not only the LCL complex, but also the lateral capsule, anchor knees, and all lateral structures are in my imbrication. So I'll show you the result of it. So this is without tension on the sutures, so we can actually almost dislocate the elbow there. You can see the entire radial head, and then we put tension on, and as you can see, my camera is pushed out of the joint and it's stabilized. So we're happy with that. Take out the camera and then tie the sutures. I tie them separately because I want to avoid a huge knot in on the lateral side. So I'm going to leave you with this. Almost everything can be done arthroscopically. Almost anything that you think of, you can do it arthroscopically. But as you know, arthroscopic elbow arthroscopy has some disadvantages. Nerve injuries have been described and are not that uncommon. So definitely stay safe. Thank you.
Thank you very much, Roger. And currently we do not have any questions from the audience here, so I will move on to the next topic. KILIAN?
Yeah, we are happy to invite or to introduce Paolo Arrigoni from Italy, and he will talk about the pathology that he actually is the describer of. It's a smile lesion, and we're looking forward to his talk on this interesting topic. Paolo's talk also is pre-recorded, so I think it's going to start any second.
Good morning, everyone, and I'm very sorry for not being directly live with you, but I'll try to do my best to talk about smile lesions of the elbow. Actually, the baseline of the model, the pathological model of smile lesion, is the continuous varus pronation that we continuously have in our elbow. If we think to daily activity and desk activities, the majority of them are done in a flexion that stays in between 70 and 45 degrees with a continuous rotation from neutral to pronational. That's think to standard activities like the ones that are represented here. And the idea that is in between this model is that progressively there is an elongation of the radial band of the LCL that continues into the annular ligament. And this has nothing to do with the ulnar band. And progressively, what happens is that the ECRB tendon and more extensively the extensor tendons are working or are pushed to work as static stabilizer, whether they theoretically are dynamic stabilizers. So in this dynamic stabilization, we have ECRB that goes under continuous tension, and this creates late failure and tendinopathy. So someone sometimes ask me if in my mind there is not everything is in particular is my lesions. No, I do not. I do think that there is a pain and on the tendon, and this pain is extra-articular. I just think that this is the effect and not the cause. So we're talking more about an horizontal instability of the radial head into the fossa, the sigmoid fossa, as a primum movens for a lot of pathology, mainly chondropathy, because if the radial head moves more because of the annular ligament is incompetent, then you can develop chondropathies that are primarily of the vertical aspect of the radial head cartilage, as you can see here in this MRI and image. Radial neck exposure goes with what we call the loose collar sign. So it's an annular ligament at 90 degrees of flexion. That is the one we use for arthroscopy, that is so low that we easily see the neck of the radial head, and causes what we call the radial head ballotment. So pushing the radial head posterior to anterior, there is a clear excursion of the radial head to move into its space. Sometimes we don't see the loose collar sign because there is a synovitis in front of the radial head. The synovitis is the one you are going to see later. That is the most common sign you can find, is the most specific one you can find in imaging as well. So going into a bit more the type of instability and the type of motion we have inside of the joint, we have on the left a case of a person that dislocated 4 times. And what's interesting is that when we try with a blunt trocar to enter into the space in between radial head and sigmoid fossa, there is not a big motion. So at the same time, there is a movement of the whole forearm. So in this case, it's the unit of radial head and ulna that opens up at the greater sigmoid notch with respect to the humerus. In a case of pain and minor instability, instead, there is a clear displacement anterior of the radial head, a clear radial head ballotment, someone would say, and we easily enter with a blunt trocar. Of course, so in this case, it's more of the horizontal, the level of instability or the level of hyperlaxity. Of course, it's always difficult to define what is normal, because of course there is a displacement that is normal and what is pathologic, but together with a long history of pain, by definition, there are some problems inside of that joint. In the anterior compartment, in the late phases of the pathology, you have 2 lesions that are kissing each other. One is a hole into the capsule at the anterolateral aspect of the capsule where the radial band is, and 2 is the chondropathy of the anterolateral side of the capitellum, also named KLAC lesion. So trying to summarize and to understand the cascade that we are facing, because of the varus pronation, we have an elongation of the radial band together with the annular ligament. There is a tentative reduction, continuous reduction of the ECRB tendon. After a certain point, we have an horizontal instability that creates chondropathies, synovitis, and eventually a capsular tear. So the first point that I want to stress is that to understand a bit more of what's happening inside of the joint, you need an exam that enhances the pathological aspects inside of the joint. So you cannot ask for just an ultrasound. You need either a CT or an MRI. I do not have instruments at the moment to say what's better than the other, because the CT is superior for definition. The MRI gives you other elements inside of the joint. So it's an arthro CT, what we normally do. And what we normally do is an arthro CT inflection, because we don't use our elbows in extension. So after a period, I started to think that there was no reason to ask for exams in extension. So our goal is to do a dynamic ultrasound plus arthro CT. And the results of arthro CT of the first series we studied, and we are actually trying to merge all this data into a score, are that if you look for one of these four signs, so chondropathy, synovitis, impregnation of the iodinated fluid into the capsule, and a loose color sign, there is a high relationship in between a patient with lateral elbow pain and having 3 or more signs respect to the population that do not present lateral elbow pain. So the exam is interesting and is performing quite well. Going into studies that do define the role of the radial band of the elbow, we set up a cadaver setting in which we put 10 fresh frozen cadavers in this hanging position, so the position that we were talking about before, so something about 60 degrees of flexion, with a weight into the hand that progressively is increased. So the testing sequence was just under gravity, or with 0.5 kilograms, or with 1 kilogram applied to the hand. And we were doing 4 steps of releases, no releases, releases of the anterior half of the common extensor origin, just to understand a procedure that is commonly done in the Niersch procedure, pie crusting of the radial band, and complete release of the radial band. I want to stress that in all these steps, we were very careful to completely preserve the ulnar band, so the LUCL of the posterior, or whatever was in the posterior aspects of the common extensor origin, was completely left in the original position. And we were studying dynamic ultrasound examination with lateral joint line widening, the angle lambda, and fluoroscopy, trying to understand the varus joint angulation. There were significant changes in the alpha angle after each release, and every increase of weight determined a significant effect on the alpha angle. So we described a linear regression model that is super complex. I don't want to stress you too much with this, but just to bring you to the conclusion, a damage of the anterior half of the common extensor origin, either an damage meaning several cortisone injections, or a specific surgical procedure in which you release the common extensor origin, brings the patient into a condition that is something like constantly carrying a weight that sounds like a bottle of beer on a healthy elbow. So you are increasing the stress, you're not releasing the stress. Then, of course, something that a model cannot reproduce is the role of the scarring process after having done this procedure. But this is one of the things to be kept in mind. The second thing is that even the ultrasound detects a difference, but is not able, an ultrasound, to detect a problem of the radial band, but just changes related to the common extensor origin. So it's a good surface exam, doesn't give us a lot of elements on the deep portion of the joint. So what we started to do years ago was to apply KATO to reinforce the radial band with an anchor that is positioned very high at the capitellar level. This is a situation, an intraoperative video of what we do during arthroscopy. So we were testing, here we are testing, we are with the scope in the anteromedial portal, we are testing and we are probing how to reduce the anterolateral capsule. The radial band has a great excursion anteroposteriorly. So we position a very high anchor at the capitellar level, and with the technique that is a classic outing technique with shuttle sutures into the level of the joint. We tend to position sutures higher than the radial head level for two reasons. One is not to placate too much, and second is because the radial nerve is just in front of the radial head, so we don't want to arrive to placate and put sutures very anterior to the radial head, but just on the lateral or anterolateral side. This is another way to do. We clean we were from posterior first, then anteriorly, we position the anchor, pass the sutures, and at the end is the reduction where we have with the radial head that is nicely repositioned and there is no allotment anymore. An eventuality is to do a knotless technique with hole first, and then we pass a suture, and then we enter this an anchor that is positioned at the same level. So I don't think at the moment, and I don't have instruments also because I didn't test the clinical results in different ways of doing that. So I'm not suggesting one thing in respect to the others. Do whatever you want. I don't think that doing knotless theoretically is better because you don't have the knot under the skin, and sometimes patients can complain about the knot under the skin, but on the other side it's more complex to do the procedure. So thank you so much for the attention, and I really hope this webinar can go on with a lot of very interesting presentation. The program sounds very, very interesting. Thank you so much.
Thank you, Dr. Paolo. I think we had a very interesting overview on lateral elbow pain from pathology to arthroscopic management, and even advanced the concept of smile lesion. So now it's time for a case discussion. I think Dr. CHRISTOS from Germany and Dr. Erika Colin from Indonesia prepared a short presentation for our discussion. Please.
Thank you, Inho. So we were actually trying first to show some cases what we see most of the time actually on the lateral side of the elbow, some things that kind of imitate the epicondylitis, or we see it most of the time in combination. That's why I'm going to let Erika start with the first case.
Okay, thank you, Chris, and hi, everyone. So let's have three cases and one radial tunnel syndrome. So the first case is a middle-aged guy. He's a manual labor with a painful snap on the left lateral elbow. So the first question will be, he got this MRI plica on the ventral lateral side. So I would like to ask the panels, everybody can answer, how often do you see this kind of case? Maybe start from Chris. You see this case often in your clinic?
The anterior plica, I have to admit, I see it like less often than the posterior lateral plica. What's even like 90% of the cases actually, if we go through the literature. I have to say, like, I see it like maybe once or twice a year. I don't see it that often as the posterolateral plica.
Yeah, I also only saw once in these 2 years, but mostly they are not snapping, and mostly they are in the dorsal-radial sides. So while waiting for another comment, let's go on to the second slide. So with a tennis elbow, sometimes they can be very typical, like described by Guido. But sometimes they're a bit weird. And how do you assess this kind of patient? The patient got a snapping elbow, painful. How do you diagnose this? What kind of plica are we facing? So, any comments, or perhaps Chris? This is
the... I'm gonna go again. So, like for me, even my standard clinical examination, this provocation test, especially for the posterolateral plica, of course for the anterior one as well, but it's standard because this is most of the time what I see in combination with epicondylitis, or sometimes it's just that, as Roger said. Actually, especially in young men, you see most of the time plica or OCD, for example. And the provocation test, what you can see actually on the AGA page, is supination extension at the same time as just pressing. You have some tenderness on the soft spot on the posterolateral side. And most of the time it's something that we don't really see on the MRI. You don't see it all the time. It's clinical. It's a clinical finding at the end of the day.
Yeah. Okay.
Dr. KILIAN, anything to add?
Well, no, I think they've covered it all. Yeah.
Okay. Right. Okay, I have a tips maybe. How do you differentiate this pain is coming from the plica or the tennis elbow? I think what I use is injection in the dorsal-radial side, the soft spot. If it can relieve some pain while the patient supinate and extend the elbow, I think the pain is coming mostly from the plica. Any opinion on this? How do you run the differential diagnosis in the clinic?
I totally agree with you, but sometimes I think we don't really have the time to do all this infiltration in the clinic, at least. So sometimes it's the tenderness. What you have, if you just press on the soft spot there, it's you can find out what that is, even in the clinical examination. And this is actually the plus, the advantage of the arthroscopy. That's what we wanted to stress on the end of the day, because you see all the pathological findings that you might have in the elbow in all compartments and in all the joints, because it's not just one joint.
Yeah, I completely agree with Christos. I mean, when you have a patient with epicondylitis, the patient refer the pain exactly in the extensor carpi radialis brevis. The pain is a hard pain. But when the patient has a plica, maybe the pain maybe it's not that well defined. That is a key to start to thinking in a plica. And it's just to add that.
Okay, so we have the first case is lateral epicondylitis with a plica, right? So actually, not all plica is innocent and not all plica is guilty, right? Which one is guilty, which one is innocent? So this is what we would like to know. So any tips or experience from the senior panels, maybe? So these are what you can see on the MRI. These are the nice picture from Chris, right? The right one is my sister's drawing, so it's a schematic. Just want you to know where is exactly what are we talking about? The C alphabet, right? Okay. Anything to share? How do we know is this a pathologic plica or not?
I would like to ask maybe Roger, if you do your tennis elbow, as you showed us, like the debridement, the ECRB debridement, you resect your plica anyway, don't you?
Roger is not online.
He's not online. KILIAN, what about you? What about you? You do anyway, you resect your plica because you're going to see your radial head from the posterolateral side. So you resect the plica anyway. So even if you do the tennis elbow, the arthroscopic ECRB release, or debridement.
I don't think it's necessary to resect the plica to see the radial head. You can just push it away. I resect plica only when it's scarred, or the size is like overreaching the rim of the head. And otherwise, I think in an MRI like this, to me, I would rather go for the epicondylitis as a pathology in this case. But it remains a pathology to be differentiated very hardly.
Okay. So it's an intraoperative decision with the plica.
I have to say, I always resect the plica, like if I go posterolaterally, because even though it's even proven that if you resect the plica, so you prolong kind of the whole postoperative care and stuff. I do it anyway, so I'm sure that I don't have it. I'm not going to have the patient is not going to have any problems in the future.
Okay. Okay. So it's intraoperative decision. Okay.
Okay.
So it's an intraoperative decision with the plica.
Mm-hmm.
Okay.
Yeah. I have to say, I always resect the plica because even though it's, even proven that if you resect the plica, so you prolong kind of the whole postoperative care and stuff, I do it anyway, so I'm sure that I don't have it. I'm not going to have the patient is not going to have any problems in the future.
Yes, I think it's quite right. Erica, maybe she is the best person to describe this plica issue because you published that paper which I read before. And thing is, your intraoperative assessment is important. When you put your scope in during your elbow flexion extension, you can recreate the snapping. And if it is really that snapping, because Michael Hausman from New York, he described the wonderful meniscocapsular complex before. So it depends on the thickness and also the movement of this plica. But my question still is, that plica has been there for many, many years, but what exactly caused that, symptomatic plica after a certain time? So this is something we cannot answer, but maybe Dr. PAOLO, he had the same, description. As you have more and more capsular redundancy and microscopic tear, maybe that changes this meniscocapsular complex or plica movement so that it can be painful sometimes. So we do not know the answer yet. Thank you.
So at least from a systematic review, I found from the literatures, if the plica is posterolateral, is 89.3% pathologic or symptomatic, or if it's thick more than 3 millimeter, or it's covered more than 1/3 of the radial head. All right, let's go to the next one. So we know that the plica itself can cause pain. It is already described by Dr. Arrigoni, so I will not emphasize on this anymore. So the plica resection, this is a slight procrease. So I can see that his viewing portal is the high posterolateral portal.
Yeah, that's right.
Go ahead, please, Chris.
Yeah. The viewing portal is the high posterolateral portal, and the subsequent portal is my working portal. So actually, most of us resect the posterolateral plica from there. It's a kind of an easy technique. I don't think I have to explain this one. In this case, it was a patient actually after a radial head fracture that he was conservatively treated. He was having pain, and after this plica resection, actually, he was pain-free.
Right. Okay, without further ado, we still have 8 minutes to go. Go to the next case, case number 2. So this is a middle-aged housewife with a 9 months left lateral elbow pain. She got, as many Indonesian will have, a history of multiple steroid injection. I'm not sure what happened in your own country. Maybe you can also share with us, is steroid injection to the lateral elbow is popular among your patients? Okay, range of motion wise, she got only 30 degree of pronation lag, a tenderness of over the extensor origin. Varus laxity is positive, pivot shift is negative. Let's see the X-ray. We can see that there is a radiocapital joint widening on the plain X-ray. And MRI-wise, looks very intimidating. Complete humeral attachment tear of the LUCL and RCL. So, any comment on the steroid injection lady or patients with lateral epicondylitis? Do you see this instability or not?
Erica, I think we can explain actually the case because we are kind of a shorter time. As we actually see that the problem here is the instability, and we see there is no LCL complex anymore. And you can go on with the slides because it's a sexy technique there, what you've done. I think, Inho, it's coming from you. Right? So with palmaris longus, you did the LUCL reconstruction arthroscopically, yes?
Yes.
So Dr. KILIAN, we would like to hear somewhat different idea from different areas. Dr. KILIAN, how you access this sort of patients in Germany?
In patients with a PLRI,
multiple steroid injection with the pain.
If they have instability, pain, and the absence of the root of the LCL, we perform a ligament reconstruction using different autografts. I'm not a fan of allografts. and we use triceps and then palmaris longus, anything that you prefer or you have experience with. I don't think that there's too much of a difference in the autografts for the result. How did your case go out, Erica? Because we need to move on quickly.
Okay, so steroid injection instability associated with lateral pecondilitis is not uncommon. So with this case, we perform a LVCA reconstruction with palmaris longus. The humeral fixation is with anchor, and the ulnar fixation is with transosseous. So this is before the reconstruction. This is after the reconstruction. So before we went to the third case, any comment? Or
Erica, sorry, we don't have time for the third case. I'm really sorry.
All right. Okay.
We're so much under pressure. We're already 15 minutes in this now, and I'm sorry. I think these were beautiful cases. Excellent. The intraoperative images are very impressive. And an arthroscopic technique actually, or probably has advantages towards the soft tissue preservation. So we're going to move on to the next talk, which is the management of acute elbow dislocation, and it's the second most common dislocation in the human. And that's a talk from Germany, Michael HACKL. It's a pleasure to have you here. Looking forward to your talk.
Yes, thank you, KILIAN, for the introduction. I hope you all can hear me. Thank you for the invitation as well. I'm going to go straight on to the center of the topic since we are a little short-pressed in time. I don't want to go too far into the background of elbow dislocation, but want to go with you right into the management, into the treatment of this pathology. If we look at the literature, there's a lot of papers out there published to compare which treatment method works best. We have this paper, a very important one that was published almost 35 years ago, where 3 groups were examined. You had one group that was immobilized after closed reduction of a simple elbow dislocation for up to 2 weeks, one that was immobilized 2 to 3.5 weeks, and a third group that was immobilized for more than 3 weeks. And the authors found that the longer you immobilize these patients, the more flexion contracture and also the more pain they are going to get. There was basically a linear relationship between the duration of immobilization and the flexion contracture that the patients developed. So our goal should be to get these patients moving as quickly as possible. The most important study, I think, on this topic is this randomized controlled trial from the group of Denise Eigendahl that was published a couple of years ago on 100 patients and that were followed up for 1 year. We have to say as a limitation, somewhat of a limitation to this study, that people or that patients that redislocated or had gross instability were excluded from this study. So this is something that has to be remembered. They compared early functional treatment without immobilization with patients that were immobilized for 3 weeks, and they found that the function was recovering much quicker in the patients who were treated with an early functional treatment regimen, which is obvious. If you don't immobilize patients, they're going to start moving much faster. And also the ROM loss was less in the patients who were treated early functional. The only thing that was of advantage in the patients who were immobilized was that they had less pain after 1 week. At 12 months, there was no relevant difference, no significant difference in any of the examined factors in this case series or in this study. None of the patients dislocated, maybe because the patients who were grossly unstable were excluded. We also did a systematic review on this topic a couple of years ago and found out that additionally to the study of the group of Eigendahl, that also the return to work is faster in patients, who were treated with an early functional treatment regimen, which is also obvious. So I think the evidence-based standard for simple elbow dislocation remains the conservative treatment without immobilization or without a relevantly long immobilization. How do we do it, or how do I do it? Important guidelines for me: you can do a short-term immobilization for patients to avoid them being too painful. Don't leave them in there for too long, 3 to 5 days, maybe up to a week, but not longer. No load bearing for the first 6 weeks. Avoid varus and valgus stress, especially the varus stress. You have to explain to your patients how to avoid to apply varus stress on your elbow, because it is not as obvious for your patient as it is for you. We like to do this overhead motion protocol, which was described by Schreiber a couple of years ago, which works very well due to this the gravity-assisted reduction of the joint. Patients feel much more have a feeling of much more stability, and it adds in regaining the function much quicker. Hinged orthoses are discussed controversially. I think they can be of help for patients, but you have to counsel the patients how to apply them correctly, how to use them correctly, and that they don't take over the work for them. They have to actively move their elbow, because we know that from passive range of motion, the elbow is not going to be stabilized. Follow-up radiographs, I think, in my clinical practice are important. If you have an initial drop sign, you have to follow up on that. Similar to shoulder dislocation, this usually goes away. If it doesn't, you have to be careful. And this might be patients who are more grossly unstable and might benefit from surgery. We have here a typical case example that I see frequently in clinical practice: a patient that was referred to us who had a simple elbow dislocation, 6 years old. He had a climbing accident, has a total tear of his medial lateral collateral ligaments along with the common extensors, and it is described in the MRI that the brachialis muscle is torn. One diagnosis that a lot of times is wrong, in my opinion. If you look here carefully at the brachialis is perfectly intact, is not torn. There's just some edema at the medial aspect of the joint, and these patients can be handled conservatively. Don't rely too much on MRI results and MRI diagnoses. In simple elbow dislocations, your patients are always going to come to you with MRIs, and they read torn ligament, torn tendon, and they are totally frustrated and think they have to undergo surgery. It's not necessarily the case. Most of these patients you can treat conservatively. Not all of your patients, however, are going to do well. This is a study from Anakwe et al. That shows that more than half of the patients have residual stiffness, have residual pain, and some have also residual instability. However, this does not mean, and this is also a study that was done more than 30 years ago, which showed that surgery alone is not the solution to this. Just because you do surgery on a patient does not mean it's going to have your patient is going to have a better outcome. So when do we need to operate? I want to quickly describe or show you 3 cases where I think you might consider surgery. This is a young professional athlete who was fairly unstable upon clinical exam and who wanted to get back to his sport as quick as possible. He could not wait for 6 to 8 weeks. He was at the end of the season with the playoffs starting, and he wanted to get back into his sport as fast as he could. So we went for surgery, and this is how we do it. We put into suture anchors into the origin of the lateral and medial, if the medial side is also fairly unstable in the medial side. Usually the extensor tendons are torn as well, so we put in an additional anchor here. And if the flexor tendons are torn as well, you can put in a 4th one here. Usually in the classic dislocation pattern as described by Driscoll, you will find that the flexor tendons are typically intact. Here is a similar case. This is not the identical case, but I don't have a video from this, from the case I just showed you. You don't want to do too much. I do it open. You just open up the fascia. You don't have to use a knife to detach additional structures. You just create the origin of the lateral collateral ligament, put in a suture anchor, and then you tie down your ligament back onto the bone. Put in stitches. I put in a mattress stitch first in front, then in the back, and then you can apply some pressure, and you see that you can nicely reduce this ligament and extensor tendon complex and close the fascia over it, and you're done at the lateral side. This is a typical case of the medial side. You split the flexor tendon muscles. Usually they are not torn off bone. You please don't release them off the bone. You don't want to cause additional harm by doing the surgery. Here you see the medial collateral ligament just by splitting the muscles. In the back you see the ulnar nerve. Then you go in front, split your flexor tendons, and you can expose the medial collateral ligament without harming or without releasing the muscles. And then you can reattach it using a suture anchor. Another group that might benefit from surgery, in my opinion, are overhead athletes that had a severe valgus trauma. You see a typical case here of a handball player who had a valgus trauma when throwing the ball with dislocation. And sometimes in these cases, the soft tissue disruption on the medial side is much more severe than you find it with these typical posterolateral dislocations. And a last group are elderly patients who have redislocations. Those patients are also some that might benefit from surgery. You see here this MRI with incongruity of the joint. In recent years, you would have applied maybe an external fixator, but nowadays, I personally prefer to do an internal brace on these patients where you put in, you see here this torn ligament complex, and we put in one suture anchor at the insertional point of the LUCL. In this case, you see here we expose the supinator crest. You put in one suture anchor loaded with a suture tape, and then you put this tape into the rotational center of the capitellum, and you augment your ligament repair. And you can tie down the LUCL or you can tie down the extensor tendons over it. I went a tiny bit over time, sorry for that. To conclude, non-operative treatment is the standard of care for simple elbow dislocation. Short-time immobilization might be beneficial for your patients. Early functional treatment should be performed. Counsel your patients, not all of them will do well. You have to follow up on them. For surgery, we don't really have literature that helps us, but in cases of pronounced instability, you should consider it. Thank you for your invitation and your attention.
Michael, it was an excellent overview, and I love your presentation and gentle reminder to all of us that the conservative management for simple elbow dislocation should not be underestimated. Thank you very much. And we'll move on to the next talk. Dr. CHOLAWISH CHANLALIT from Thailand is going to talk about arthroscopic management for elbow instability. Over to you, CHOLAWISH. You are muted.
Hello? You hear me already, right? Okay. Okay, good afternoon. SICOT Mid Europe. I'm CHOLAWISH CHANLALIT from Mahachakti Sirinthorn Medical Center, Sinakulimilot University, Thailand. This is my video, so basic concept for develop of my arthroscopic technique. Most of the arthroscopic technique for the lateral elbow ligament reconstruction are based on pigation or implication on the non-functional ligament. In ankle, modified Boolstorm is successful to restore ankle stability by wrap around the retinaculum ligament for tissue or augmentation. So how about the elbow, maybe ankle nears? Annular ligament insert is common with LUCL, This knowledge, Min Jong Park report the successful reconstruction tendon that insert in annular ligament and redirection it as LRCL. Erika and Inho with their group had a study series. They show the mechanoreceptor in capsule and collateral ligament as they condensed in the bony insertion. All of those concepts, we developed the technique for correct the posterolateral rotatory instability. Please enjoy the video.
Position with the proximal arm support. Pneumatic tunicate was applied to the vermost proximal part of the arm. First, we worked on the anterior compartment by using proximal anteromedial and anterolateral portals. And the presence of concomitant lesions in the anterior compartment, such as tennis elbow or plica, could be treated in this step of the procedure. In this case, the extensor carpi radialis brevis was tenotomized by motorized Java. Two more portals were created, which were direct posterior portal as a viewing portal, and posterolateral portal as a working portal. Excessive synovial tissue was debrided and removed for a better visualization. During the arthroscopy, a drive-through sign was tested with the elbow in the extension posture. The test would be positive when the camera sheath can be driven through the lateral gutter. Then, the ulnohumeral gap widening sign was tested. During the test, the forearm should be in the forced supination posture, and the arm should be stabilized by an assistant to avoid shoulder rotation. The test would be considered positive when the ulnohumeral gap is wider than 2 millimeters or wider than the tip of the probe. After finishing with the instability tests, the lateral olecranon plica and posterolateral plica were resected. Then, the annular ligament was identified. A small incision was created posteriorly to the radial head. Subcutaneous tissue above the anconis fascia was resected. Through this incision, the suture passer was used to penetrate the anconis fascia, anconis muscle, joint capsule, annular ligament, and finally into the joint. A lesser loop was retrieved via posterolateral portal. A number 2 hyphae was passed back through the small incision. Then, repeat, using suture passer, and also repeat, passing another number 2 hyphae. So, at this moment, there were 2 strands of number 2 hyphae that went through the posterolateral portal into the joint, and then through annular ligament and anconis muscle, and finally throughout the small incision. Now, the cortex on the posterior and inferior aspect of the lateral epicondyle was decorticated. A 2.8 mm drill was used to create a tunnel for an application of a pop-lock anchor. A subcutaneous tunnel was created between the small incision and the posterolateral portal. Then, the sutures was retrieved from the small incision and was passed through the subcutaneous tunnel and out to the posterolateral portal. Now, 4 of the suture ends were out in the posterolateral portal, of which 2 ends were originally from the posterolateral portal, and the other 2 were from the subcutaneous tunnel. All the suture ends were applied to the 2.8 mm pop-lock anchor. Pop-lock anchor was applied via the posterolateral portal. The sutures were tightened to the pop-lock. As you can see, the lateral gutter was narrowed and the ulnohumeral gap was closed. The drive-through sign and the ulnohumeral gap widening sign were negative after these procedures. Thank you for your attention.
Here is the case: 40-year-old male, soil, ship-open pain and instability of his elbow. History elbow dislocation 1 year ago. In the volar arthroscope, you can see that the posterolateral downward test was grade 2, condyle perch on the edge of the lateral head. The surgical technique, same as previous video. This is the result. He can back to push up. We just published the case report of elbow dislocation in primary lateral sclerotic patient. General muscle weakness. She recently get the acute elbow dislocation 2 months before the elbow dislocation. She also get the 2 times of elbow injury and subluxation because her weakness condition. In this case, I don't want to surgery on her with the surgery that can more damage on her muscle. And I quite question on the soft tissue quality, such as the LCL complex. In this case, some variation was done by changing the ankle from knotless ankle to be soft ankle suture. That I believe the knot tying can make more pigation on the annular ligament and collateral complex. So the suture management be the same 2 tails of the suture in the joint, and another 2 tails of the suture pass in the subcutaneous channel, and all of the suture tails exist from the small incision and make a knot tying. And here the result. Workout wall stability is stable and her range of motion return back. In automatic PLI is existed, right? Many literature there. In this case, I just want to show some evidence of harmful steroid injection. Here is 38-year-old female lateral elbow pain more than 1 year. In the first MRI, she got 6 months before met me. The first one is after the steroid injection. You can see that 6 months later, when she come to consult me, the mallow contusion is gone, but unluckily she got the post-operative lower test when compared to another elbow. Here is a 45-year-old male, chronic lateral elbow pain with a 5 times steroid injection. Yeah, Thailand land of steroid too. This video shows the clinical size of the post-operative lower test. In this one, capsular defect and pica were found, so we get rid of those lesions. The LCL reconstruction, in this situation, a traumatic PLI, the laxity is not so severe. So I use the soft ankle, 4 tail of the suture, pass the annular ligament and fascia, and exit to the small incision behind the radial head. And in the diagram, you can see that the two tail of the blue suture and 2 tail of the white suture, and tie the knot over the small incision behind the radial head and make an indication. Post-op program, apply brace for 6 weeks, limit extension in initially and subsequent release in extension. We just published the result in 8 patient automatic PLI. Age average was 49, mean follow-up was 16 months after surgery. 4 times steroid injection, all of them improved significantly in quick dash score, major elbow performance index, and visual log scale. All of them, the range of motion returned back to normal when compared to the contralateral elbow. The limitation may be not too good for the loose joint, such as a post-operative downward test grade 3. So I think that the tendon reconstruction, use the tendon for ligament reconstruction may be the best one. In the case of medial lateral instability, this situation box loop reconstruction may be proper choice. In the case that elbow was power alignment and subsequent with post-lateral rotatory instability, the treatment in this situation was the correct alignment, and the ligament reconstruction are the best choice of the treatment. Thank you. I think I'm in time, right?
Yes, you were excellent in time. That was perfect. On point. Thank you very much for this excellent talk. Very interesting technique. And we move on to the last segment of the meeting. And this is another case discussion, conservative versus operative, from AASHAY, KEKATPURE, and LEONARD. Pleased to meet you and looking forward to your talks.
Yeah, welcome from my side. Thank you for the invitation. Thank you for the organization from this great online meeting. I've learned a lot, and I hope to contribute with this case. It starts unusual. It's a professional handball player, but he had a shoulder contusion. He was referred to us for return to play assessment from another medical team. A time loss of 23 days, and then we tested him. And in the upper side of the presentation, you see the psychological readiness, and I marked everything in red because everything was a bit strange with him. He wasn't really ready psychologically, and in terms of sports motoric assessment, he also failed several tests. So in our case, he wouldn't be cleared, but the medical department from the other from his team, they cleared him for readiness. And as is most of the case, if you have a previous injury which is not healed completely, they have a second injury. And in this case, he was returned to competition 6 weeks after his injury, and he fell on his injured shoulder side, on his non-dominant side. And he had elbow pain, and he discontinued the match, and then he presented to us again. And he had a swelling and hematoma of the radial elbow. He had tenderness on the radial epicondyle, no tenderness on the CHRISTOS supinatoris. He had an unstable elbow and varus stress test. And something I really liked was the hypersupination test for the LOCL described by O'Driscoll, which was stable in his case. These are his x-rays, which look fine to me, especially no bony fracture, but we can see a loose body in the anterior compartment. But it didn't bother him before. He said he didn't have any problems with the elbow before. And you can, in the MRI, you can see a tear of the radial collateral ligament. The LOCL was fine, and an avulsion of the extensor carpi ulnaris and extensor digiti minimi tendon. So now it's open to discussion. We had a fantastic talk by Michael before, how he should treat it. I'm not sure how we are in time if we can discuss it. So I go straight to our solution. And in our case, we treated him conservatively, although he's a professional player, but it was his non-dominant hand. So we decided we immobilize him in this time in a cast, especially because he's a professional player, and we doubted he would take on the orthosis the whole time. And we had it in maximum pronation to increase the healing potential for the lateral ligaments, and then a gradual increase in range of motion with an elbow orthosis after these 10 days. We also like the overhead motion protocol, and then a gradual return to activity, return to play in competition. And for the return to play, he had to pass all the previously mentioned tests. And we consider at least 90% of the opposite side to be the threshold that he has to reach. Yeah, thank you very much. That was my case. If you have any questions, let me know.
Thank you. Shall we finish our talk after AASHAY's presentation?
Yeah, we'll head over to Ashi.
Share my screen. So, for the sake of time, we will just jump into the case. So, a lot of talk, excellent presentation regarding lateral and PLRI reconstructions. My talk will be about medial collaterals. So we have got a 26-year-old male kabaddi player presented with a history of injury to the right elbow 3 months back. He took local treatment in terms of massage and immobilization, and now presented after 3 months with instability and weakness of the elbow. He is not able to throw or tackle anymore. So I hope you are seeing the GIF. So that's how well the moving valgus stress test was positive. How we do it? It's like a milking test for the partial tears. Moderate valgus force applied to the arm in full flexion, and arm is quickly extended. When the test is positive, when the pain is between 120 and 117 degrees. So pain at full extension or flexion may represent a different source of pain. So quick overview of the medial elbow, the anterior most fibers. This is, thank you, Dr. Inho, for the slides, is most valuable form of stabilizer against the valgus force. The posterior is the second most important stabilizer, whereas the transverse is minimally important to the stabilization of the elbow. So this is the X-ray. So it's very peculiar X-ray. He has got a medial epicondyle fracture, avulsion fracture. Now it's 3 months. So getting it back with a screw was an improbable situation, and something was happening on the lateral side. Mostly because of the massage he has received, there is some amount of how can I say bone HO, but his lateral collateral side was stable. Unfortunately, there was no MRI, so we will directly jump what exactly we have done. So we reconstructed the medial collateral ligament. So for that, important steps are preservation of the flexor pronator muscle mass, protection of the ulnar nerve and the antebrachial nerve, removal of the calcification, and bone tunnel at the isometric points. There could be a debate on this point, and you can fix the autograft, the palmaris longorum, either with an interference screw or with a docking method. So this is the intra-op examination. It was opening up on the medial side, but it was stable for lateral collateral side. So we harvested the palmaris longus and the Tommy Jones was done. This is for the avulse fragment, and we fixed it, docked it on the epicondyle side and fixed on the ulnar side using a swivel lock, a 5.3 mm swivel lock. So this is the post-operative images. This is the X-ray. This is 8 weeks post-operative. I don't know whether it can work. So, can I present another one more? So, on the counter view for, the counter view for a operative management of medial collateral ligament reconstruction is this case. She's a 50-year-old anesthetist. She had a history of fall at home. Her requirement of daily living are less as compared to the athlete which we have seen. There was pain and difficulty in flexion and extension, and there was subtle instability. So this was the day 1 picture. This was the X-ray. I mean, it was not very much remarkable, but the MRI showed a small tear. So I conserved it. And then this is yesterday's. So she's doing absolutely fine. So talking about MCL reconstruction results, if in a properly selected population group, in an athlete or a high demand athlete, usually a MCL reconstruction usually gives a very good result, with more than 80% of them returning back to the previous competitive level. Only 5% in a series reported by Thompson had a transient ulnar nerve symptoms, whereas if they are treated conservatively, non-surgically, only 42% of the athletic population returned to the level of competition. So we need to really choose our patients well, whom we want to operate and go ahead with a surgical reconstruction in terms of using an autograft, or we plan to conserve. So clinical examination with a valgus stress test, imaging with an MRI when in doubt, and need to differentiate the demands of the patient for treatment modality. Thank you. Thank you for your attention.
KILIAN, over to you.
Yeah, thanks. Excellent timing. So I think despite the time pressure, we've kept the schedule in pretty well. I don't know if any one of you has received questions from the audience.
KILIAN, before we close this session, I would like to ask you to share your expert's opinion on the early primary repair versus conservative. When do you recommend early primary repair for simple elbow dislocation?
So I'm pretty conservative on elbow dislocations if there's no bone involvement, and I've remained that way over the years. because my experience is that with patient, so if you are patient, with the clinical results of your patients, they will develop good range of motion and an adequate joint stability if you treat them conservative. However, there's two groups that I'm rather concerned, and this is on the one hand the people that are elderly and especially female and especially adipose or high weight, because they will have a bad relationship between muscle coordination and weight of the forearm. And these actually are the only patients that I have witnessed during the last, let's say, 14, 15 years in my clinical experience that developed a malignant elbow instability with chronic sub or dislocation. And these patients then are only treated, or you can only get them to a proper function back with a total elbow arthroplasty. So with these patients, I'm really, really careful. With children, I've not seen a proper indication for surgery of the primary dislocation or a simple dislocation so far. So those I would treat conservatively. And then it's a matter of discussion for adults, males, and sports persons. And in my experience, subtle clinical examination and a follow-up of 1 or 2 weeks, so if you see them every week, you will see how they develop. And there will be some patients who will be on a decline from the first day, so they will decline in their clinical function. And then there are patients who will get better every day after the trauma that you will see them. And in those, I haven't had one coming back after like 6 or 8 months complaining about a chronic instability. Maybe I haven't met those patients, but this is my sum up for this pathology. And I would really recommend, when you do clinical examination, not put them under anesthesia and put them in the x-ray or something. Have them sit in front of you and have them have a weight in their arms and move the weight in a varus loading. And in a valgus loading if you want to, but valgus I think is not that relevant if he's not a thrower or something. But have him move a weight into varus loading. And if they're like a week after dislocation, they are like, well, I can't hold it. Maybe these are good patients for surgery. But if they're like, oh, well, that's okay. Don't do surgery on them.
Okay. Can I ask you a question, KILIAN? Like, do you do MRIs regularly in these patients after a simple dislocation? And because especially in this case, Leonard's case, there was a extensor rupture. So in these cases, I would operate on them anyway. But still, when I do, as you said, I see them after 2 weeks. If they still have pain, though, or the range of motion is exactly the same, it's not getting better. So would you consider operating on them?
So two aspects. So if they are not developing their range of motion, and that would be to me a sign of decline, but I rarely see that. If they have proper exercise, so like physio, or if they stick to the over-the-head protocol, in my experience, everybody develops range of motion if they are in a cast for weeks, or if they don't have physiotherapy, or if they're too afraid. There are people who are too afraid to do physio, and they say, oh, there's so much pain. In these patients, sometimes, they will get stiff. But if they have proper physio and you show them how they should do the physio, in my experience, they develop a good, proper range of motion. And the other question was with the MRI. So most patients to me are being sent and they already have an MRI. But I mostly look on the MRI on the end of the examination where I already have done my decision. And I do not want to miss like cartilage flakes that are entrapped in the joint, because those would get you in trouble later on. So for those, I'm happy to have an MRI. But if the joint was completely dislocated, I would assume the ligaments to be torn, and muscle tears do not push me toward surgery right away, because I've seen too many MRIs of patients who had a complete CEO avulsion or CFO avulsion, and they're being like, what's wrong with my elbow? They're happy. So I really focus on the clinical examination and their function when they're doing stuff. So I put them under stress and let them do stuff. And that's what I want to see.
Dr. Erika, do we have any guideline when we when we can do a primary repair and when we can do primary ligament reconstruction, primary repair and reconstruction. Do we have any guideline for that?
As far as I know, we don't have a exact protocol to differentiate this decision. I think for an elite professional, reconstruction might be better. Or if in a very old patient with a very fragile tissue, maybe a repair of that fragile tissue is not going to hold the elbow very well. But I don't see a long cohort to support this decision or any high-level evidence-based studies.
What about time? What about time, though? Because of the quality of the ligament, that plays an important role as well, though. Yeah, if you're going to do a repair or a reconstruction.
I don't think that there is a huge disadvantage if you do it, let's say, below 3 weeks or within 3 weeks. Even 4 weeks after 5 weeks, but I don't think. I mean, maybe that was I don't know, but I think within 4 weeks, any ligament, if it has the appropriate length, it should be better than any graft that you cut out from somewhere else, and that has to be integrated on both ends. So I would rather have a ligament to be integrated on one end.
What about the subacute zone, for example, 3 to 6 weeks, which you still repair? Because I've developed my own algorithm, for example, because I do everything arthroscopically anyway. So I'm going to do my repair arthroscopically, and then I'll just augment it maybe with an imbrication, what Roger showed, this technique, or I can kind of do what CHOLAWISH actually showed. I'm going to do, that was the third case I want to show actually, where I actually do arthroscopically. I take the extensions as well. So I kind of applicate the whole thing. So it's a repair and application at the same time.
CHRISTOS, I think it's a good idea. I would like to say this is an acute, subacute, chronic case. I would say the subacute stage is very critical and dangerous in a way, because for traumatic elbow dislocation, either you do very early or very late ligament reconstruction in a subacute phase, you have a very high chance of HO or other surgical complications. We all talk about surgical repair, but surgical repair also has cons and pros. You have to bear potential complications. How you do, Leonard?
I think in an individual case, I would base it rather conservative and try it. And if it fails, then it's a chronic case for me, and then I can have the discussion or the indication for surgery.
Sure.
For me, I think that for the subacute, whatever, if we repair back, it make everything back to normal anatomical. In that situation, the ligament is not so nice because it's subacute. So maybe the internal spin maybe have a low more than reconstruction. Because in reconstruction, you need to sacrifice another tendon or allograft, whatever there. So back to anatomical, maybe better, and also internal spin may be helpful. So the MRI maybe need to help, because sometimes internal spin such as like a mid-substance tear or maybe ulnar side can happen in there, not just the humeral size.
Good. I mean, I really enjoyed listening to the different opinions and strategies and even algorithms from all over the world. I think we all took a lot of it, a lot from it. Inho, I mean, we should summarize the meeting, I think, and come to a conclusion. I think for me, the key points were that like lateral elbow pain, we've learned that it's very complex, multifactorial. Many pathologies can be found there, and there are interestingly a lot of arthroscopic techniques. that are able to help us in these patients. I think a lot of learning and exercise is necessary to perform arthroscopic techniques in patients. And I think we should try not to exercise on our patients, but have to exercise these in courses and training courses, and especially on cadavers. There are also digital solutions available, as you all know. I don't think that we should, I don't think that digital solutions are that reliable. I don't take much from it, I have to admit, but I think cadaver training is an excellent tool. So I will all want to emphasize, every one of you, to take, I mean, all of you are instructors in cadaver courses, but the attendees, I emphasize them to take part in such courses, because you can learn so much in these courses and help our patients even better. So this is something that I've taken from it, because we have seen so many arthroscopic techniques. These are expert techniques, and for those we need a lot of training, and I think we can learn a lot for this in cadavers. And Inho, maybe you finish on the dislocation part.
Thank you very much, KILIAN. I think we had a wonderful discussion, because one of the reason why we have this combined collaborating webinar is to accept a lot of diverse ideas from all over the world. And I particularly thanks to KILIAN to have all these wonderful faculties in this webinar. I think, as I said again, this is the first time to cover the elbow pain, and we covered from the basic to the all advanced. And I think, including me, all our faculties and the participants enjoyed our webinar. I would like to say thank you for all your participation and time. So hope we can have a session 2 sooner or later. Thank you very much.
Thank you.
Yeah.
Thank you.
Thank you.
Thank you.
Bye-bye.
you.